Okay, so let's get into playing with some toys and doing some fun stuff here with oxygen delivery. So oxygen is measured in terms of liters per minute or FiO2, fraction of inspired air. So room air contains 21% oxygen or an FiO2 of 21. Oxygen rates over 3 liters a minute long term need humidification. So if your person's going home and they're on 3 or 4 liters of oxygen a minute, it wouldn't hurt to put some humidification on them. Not needed at 3 liters unless we're doing long term issues here. It tends to dry the nose out, which then has skin breakdown, nose bleeds, the whole 9 yards. So, like in the photos before, you see here on the left that the flow meter is connected to the oxygen valve, which is green. The knob here turns the oxygen up and down. And this one goes up to this particular flow meter goes up to look like 15 liters a minute. Some of them go up as high as 100, but that's for special types of equipment and so forth and so on. This other photo, like before, shows the humidification process there. So for some low flow oxygen delivery, we want to use a simple nasal cannula. Okay, at 1 to 4 liters a minute, it delivers anywhere from 24 to 40% FiO2. We can use a nasal cannula up to 6 liters a minute, but it gets to a little irritating. It tends to dry their nose out, and honestly, 6 liters and higher, about 3 liters of it is coming back out the person's nose. Okay, so you need to know the delivery systems. How many liters a minute, what FiO2, what's the limit for nasal cannula, and all these other delivery systems. You need to know these, okay? So that picture to the right on the first one is showing how you put the nasal cannula in the nose. It's a good idea to turn the oxygen on regardless of how you're delivering it and make sure it's flowing before you put it on the patient. The second thing is a simple face mask. There is no bag attached to this. It can go up to 5 to 10 liters a minute and delivers anywhere from 40 to 60% FiO2. And there's a nice little picture of that there. Okay. Rebreather mask has the bag attached to it, as you see in the video or the picture here. Can go up 5 to 15 liters a minute and delivers 90% oxygen. Unlike in the airplane, you do have to make sure that the bag is inflated here. Okay, so the bag needs to be inflated on the rebreather. Okay, so these are some high flow oxygen delivery systems, very, very high levels, concentrations of oxygen. The first on the top right there is an aerosol face mask. You'll usually see those with respiratory when they're giving some type of breathing treatment, albuterol, any kind of bronchodilator, steroid that has to be inhaled, needs a lot of pressure to be forced in. Okay, a face tent, you'll see this oftentimes post-operatively with oral facial surgeries. Very, very high rates of oxygen here, like 40, 50 liters at a time sometimes. You should have humidification going to that. And then here you have a tracheostomy or a trach collar. This individual has a tracheostomy. It's in the neck there, and then the collar is what is attached to it. And then you have a Venturi mask, which is a mix of oxygen and room air. The way we do that is there's a dial here that mixes what percent of room air versus what percent of oxygen is going to be delivered. So positioning is very important for ventilation and oxygenation. We need to make sure our people are in a position where they can mechanically breathe and they can go through the process of the gas exchange. So we need to teach our people, regardless of whether they've had surgery or not, to turn, cough, and deep breathe. That's just good pulmonary hygiene. So usually we need to keep our person in a upright and elevated position. This pushes and pulls the abdominal organs down so the diaphragm can expand and move, and the lungs can expand and deflate. Have the patient turn every couple of hours, keeps fluid from building up. If the person is very short of breath and they're weak or whatnot, have them lean forward on a bedside table, use pillows as a cushion. That's what you're seeing there in the middle two photos. And you see this young man on the left-hand side who's leaned forward a little bit. And then you see a younger man on the far right-hand side who's leaned forward a little bit. Those are called adult tripod positions, okay? The photo at the bottom of the little kid looking like he's sitting like a Native American leaning forward, that is a traditional children's um, tripod position. Those are positions that people will naturally get into in order to breathe. So this little man on the left looks like he probably has some long-standing COPD, and he sits like that all the time to breathe. Whereas this young man on the far right is doing a little bit better than I am, because it looks like he might have been doing some exercise and he's a little short of breath. So, by the way, if you ever see me running, you better run faster than me. So he's probably got some exertion going on, but he has instinctively bent down, put his hands on his knees, and that's an adult tripod position. Incentive spirometry you'll learn to use in the lab. The important thing about the incentive spirometer is remember that you suck on it like you're sucking through a straw for a big thick milkshake. You don't blow in it, you suck on it. Chest physiotherapy, that's where we beat on their back, and postural drainage is where we position them where the head and chest are lower than the rest of the body, and we can do some chest percussion and physiotherapy, beat on their back, break some secretions loose, and it allows it to drain out. So we talked earlier about paroxysmal nocturnal dyspnea or attacks of dyspnea and coughing that occur while you're asleep. This is at night, but remember, not everybody sleeps at night. It usually awakes the person from sleep, and it's rather frightening. Okay, so this picture shows what happens. The person's lying flat. The pressure rises in their left atrium. Their PO2 falls. Fluid is redistributed into the lungs, and reabsorption from fluid in the tissues in the lower extremities. So there's decreased or increased venous return. Everything shifts forward, and all of a sudden we can't breathe, and it wakes us up, and we sit straight up out of bed. We're short of breath. We're coughing. We may have some thick sputum to it. We may be pale. That's what pallor means, P-A-L-L-O-R, pale. We may be sweaty and diaphoretic. Our heart rate can go up, and I bet you if we listen to our lungs, we got a little bit of fluid in the back and lower lungs. That's called crackles, which you know from health assessment. So what causes P&D or paroxysmal nocturnal dyspnea? Any number of things: ischemic heart disease, valve disease, hypertension, cardiomyopathy, atrial fib, sometimes in mitral valve, but usually the other valves, heart failure, COPD, any number of things that can cause this. Okay, so here's our friend, the incentive spirometer. Um, it measures the volume of air moving in and out of the lungs, and it also serves as an exercise for the lungs. So we breathe slowly in and deeply as possible, holding it, and then exhale. Okay, so the person puts their lips on the mouthpiece. First of all, they blow out, then they put their lips on the mouthpiece, and then they inhale, suck like they're sucking a peanut butter milkshake. Okay, you can go to this YouTube video to choose to watch if you want to via the stagnant PowerPoints, or you can also look in your Wilkinson and Trace Volume 2 and find how to use the incentive spirometry. You are tested on this. You'll be expected to do this in the sim lab, and you will see your patients in the hospital do this. You need to know how to do an incentive spirometer. You suck, you don't blow. Okay? So some other diagnostic testing that we might do to look at oxygenation, peak flow monitoring. This measures the amount of air that can be forcibly exhaled and detects subtle changes in the condition such as asthma. There's a picture that's what's coming from page 950 of volume 1. We can do peak flows at home and have them work on increasing those. Respiratory therapy is really good at doing this, but you also need to have an understanding of what peak flow does. You will probably see this again somewhere. Electrocardiogram or ECG. Old people like me will call it an EKG. It's the same thing. We're just old and don't want to change. It detects changes in the heart rate and rhythm and how that affects oxygenation and perfusion. So we all know what EKGs are for. They're to look at the heart rhythm and rate, and they can tell us lots of interesting things. But can't tell changes unless we have an old one to compare to. You heard me earlier talk about postural drainage. This promotes drainage of fluid from the lungs. It uses gravity to do that. So here are some photos about how to help with postural drainage. The good thing in a hospital is our beds will tilt so that the head can be lower than the feet. And what's important is where you position the person so that we're draining the left side or the right side or both sides and whatever the patient will tolerate. And that's probably the more important thing is what the patient will tolerate. Okay. You don't see nurses doing this a lot. You'll see respiratory therapists doing this a lot, but it's not out of your scope of practice. You can do it. It takes a little time to get used to and whatnot, but it's a very good effective mechanism. You will see more nurses in critical care units doing this than out on the regular floor. So let's talk a little bit about diaphragmatic breathing. Those of you who do meditation or large body sports contact have learned to do diaphragmatic breathing. It's the most efficient muscle for breathing, the diaphragm is, versus your smaller chest muscles. It's dome shaped, blah, blah, blah. You all know what the diaphragm looks like. What happens with COPD and other things is lung air gets trapped in the lungs and pushes down on the diaphragm, and which then makes it unable to contract and expand up to help us breathe. It leaves it weak and flattening and doesn't work as well. So when we do diaphragmatic breathing, it's intended to help the client use the diaphragm more correctly. It strengthens the diaphragm. It decreases the work of breathing by slowing the breathing rate. It decreases our oxygen demand, and it uses less helps use less effort and energy to breathe, therefore allowing us to perfuse better. So some diaphragmatic techniques here. Place one hand on the upper chest and the other on the lower rib cage. This will allow you to feel your diaphragm as you move. Breathe in slowly through your nose so that your stomach moves against your hand. The hand of your chest should remain as still as possible. Tighten your stomach muscles, letting them fall inward as you exhale through pursed lips. The hand on your upper chest must remain as still as possible. That's the important part. Diaphragmatic breathing or the diaphragmatic breathing technique can be done in a chair. You use the same position. Keep the feet flat, relax the shoulders and neck. Need to do this 5 to 10 minutes, about 3 or 4 times a day, and this gradually increases your diaphragmatic breathing. Like I said, those of you who meditate, do yoga, Pilates, anything that involves your core, you can already do this without necessarily using your hands to change here. Okay.